It's nice to see you all. As you can hear from the chatting with Divya and Wendy, we've known each other now for several years. I'm always really grateful to be able to participate in this. It's really fun when we get to do this in person, and then it's really, very interactive as we talk. So we'll do the best we can. Anyway, Divya, or Wendy, did you want to say a couple of words?
Yeah, I just wanted to, we need to update our slides because I see you're also professor. Congratulations.
I'm going to update it right now.
And he's also director of male reproductive health at UCSF and, a nationally sought after speaker. He has quite a bit of research, particularly in the basic science investigation of sperm physiology, stem cells, and also oncofertility. So we always give you the most amount of time. We love all of our speakers, but we feel like your content is very high yield and not something most like REI fellows ever really get to hear at your level. So thank you for being here today.
Oh, it's my pleasure. And I would say, to all of you guys, as you're starting out in the field, get involved. Get involved in whatever you guys are passionate about. I mean, at the resident level, at the fellow level, just find ways to connect with the societies that you find really meaningful to you. Oncofertility Consortium is terrific. I mean, it basically brings so many of us together, from urologists, REI, oncology, hematology, nursing, advanced practice nursing. There are just so many ways, social workers, patient advocates. And so that's the reasons why I really love being a part of this group, is because all of us get to come together and share our perspectives. So you get involved and, reach out to us if you'd like to get more involved. So as far as disclosures, I'm helping out on a couple of companies in terms of helping them do things. The point of this talk today is to go over a number of things, background, to help you understand and interpret what's going on with your patients, diving a little bit more deeply into spermatogenesis, the risks of chemotherapy as you're counseling your patients, and then to talk about some experimental work, pre-pubertal fertility preservation, and then more standard of care post-pubertal fertility preservation. I am fine to stop, as we're going. I've got lots to talk about. This is one of my passions. But if there are the questions that you'd like us to stop, maybe Divya or Wendy, you could just kind of chime in and give me the hand, and I'll stop and go into more details. If there are things in the chat you think I should talk about, I have question section at the end, but I'm happy to stop anytime. So our goals for this is that you'll all be much more comfortable in terms of talking about fertility preservation options for your patients, to be able to come up with a plan that works for each person and each family unit, and then also understand how this really takes a whole team to work well. So the rationale, I mean, this is essentially, there are lots and lots of men who are diagnosed with cancer every year, and it's a big deal. It used to be in decades past that there weren't as many people who survived their cancer treatment. And so this wasn't as big of a deal, but it ends up being that reproductive health and sexual health are really, really big concerns for people afterward. For adults, fertility preservation is a standard part of what we do, but for kids, it's not the same. And you'll see as we talk today that for kids, there's some exciting stuff on the horizon, but we're not, we're not there yet in many cases. So when you're looking at your patients, the most common way that we will, as a reproductive urologist, will think about their problems is we'll think about them in terms of pre-testicular problems. So problems that are affecting the brain. And so that could be radiation, or other things that are affecting brain. It could be testicular. This is a lot of where chemotherapies or radiation is affecting testicular function, or it could be something that's affecting after sperm has been made, after it's had the correct hormonal signals. There's some kind of a blockage reason for sperm not getting out, or semen not getting out. What happens, though, is that, when you're thinking about azoospermia, we kind of tweak it a little bit, and we mostly dichotomize this. So if a patient comes in with azoospermia, we generally will think of non-obstructive azoospermia or obstructive azoospermia. And so you're lumping basically the pre-testicular folks and the testicular folks. You're using your labs, your history, your exam as a way of trying to sort out which group these patients fall into. And the treatments are drastically different from one to the next. When you're taking your history, you're, from a medical standpoint, you're trying to see which box people are fit into, and trying to see whether or not they've had a history of Kalman's. You're thinking a central problem. They're exposed to, as in in this context, they're exposed to chemotherapy and radiation therapy more directly to the testis or to the retroperitoneum that can have significant impacts. Looking at the types of surgery they've had and whether or not that's going to be affecting their ability to ejaculate, or directly obstructing something in the groin if they've had a sarcoma surgery. So moving to a case, so imagine that a 29-year-old has come into your clinic, and this 29-year-old has testicular cancer, wants to conceive, had a right testicle removal, right orchiectomy 3 years ago, and they did not bank sperm. Patient, because of the pathology results, they're at high risk for recurrence. So they underwent 3 cycles of bleomycin, etoposide, and cisplatin, BEP. Spouse is 27 years old. She's healthy, regular cycles. She's never been pregnant before. So what do we do next? So often, if I were talking to an REI group, often the next choice would be, well, of course, you get a pelvic ultrasound. So, but here we would do history. We've gotten our history. We physical exam, and we get some labs. So from a lab standpoint, when you take a look at these, this would be the point of the talk if we were in person, where I would be reaching out to the audience and I'd be asking you all to think about this and to say, when you look at this lab profile, what do you think is going on? And so what you want to do is you want to look, is this FSH, is it elevated? Is this normal? Is this testosterone elevated or normal? And so I think I'm going to answer my own question here. Generally, an FSH greater than about 8 is considered abnormal. So when you see an FSH that's 37, this is suggesting to you that the chemotherapy this patient has received has significantly affected the testicle's ability to produce sperm. And you can see when you get a couple of semen analyses that the patient does have sperm, but they're all dead, essentially. So sperm that you see that are non-motile in the ejaculate, this is telling you that these sperm are dead. The thing is that's good about that, though, is finding any sperm bodes really, really well for finding sperm in the testicle from a surgical standpoint. Now, these are not usable for IVF. They're dead. They won't fertilize. But if you get non-motile sperm from the testicle, they almost always can. So diagnosis in this case is significant testicular impairment of spermatogenesis, and you would not think that this was an obstructive case. So what's happening from an endocrine standpoint? So how can we think through this? So essentially, you're getting pulsatile release of GnRH. This is signaling to the pituitary gland to release, in the case of testosterone production, release luteinizing hormone. Luteinizing hormone is signaling to Leydig cells that sit in between seminiferous tubules to produce testosterone. Testosterone, in turn, feeds back to the hypothalamus and the pituitary to downregulate what's happening. In patients who are significantly overweight, and this happens in any fat cells, but you have aromatase, which converts some of that testosterone to estrogen, which also has a strongly inhibitory effect. Prolactin, for patients you see with prolactinomas, this also has a strongly inhibitory effect on the pituitary. Pituitary is also releasing follicle stimulating hormone, and this release stimulates the production of sperm. From Sertoli cells within the testes, you have a release of inhibin B, and inhibin B is what's signaling back to the pituitary gland that things are working well or not working really well. So the hypothalamus, it has this pulsatile release of GnRH, and these slides, I should say, Wendy and Divya, I can make available if anybody wants to just to see these. and refer back to them later on. And as I said, pituitary gland is releasing these peptide hormones, and the Leydig cells, primarily just from and I don't think this is on anybody's boards anymore. It used to be when I took our urology boards, you'd get these kind of pictures that would show up, and we would be responsible for trying to figure out what's the next step based on abnormalities. But you're finding Leydig cells in between the seminiferous tubules. There are interstitial cells, and you're seeing them in between seminiferous tubules. So if they're pointing out something that's happening in between, generally you're thinking Leydig cells. Luteinizing hormone, basically, as well as follicle stimulating hormone, once they're diffusing to the testis, to the bloodstream to the testis, these are peptide hormones. They're binding to the outside of cell membranes, and they're initiating an intracellular cascade that eventually is leading to new protein synthesis. Both LH and FSH are doing that. So when you look at your pattern of hormones, as you've taken your history, you've done a physical exam, you're looking at this. When you have patients with testis failure, you're generally going to have either normal or somewhat low testosterone. Your FSH is usually high. The luteinizing hormone can be normal, or it can sometimes be high. Prolactin, inhibin B, prolactin is generally normal, and inhibin B is typically low. But you're looking at this pattern to help you sort out what may be going on. If everything looks normal, then likely this is pushing you toward an obstructive case. If a person had had central radiation for a brain tumor or something like that, then typically you'll see this more like a Kalman's syndrome type of patient. You'll have low T, low FSH, low LH. In the case of a prolactin producing tumor, things will be low. Your labs will generally be low, but your prolactin would be quite high. And often this is 75, 100, 150, something like that of a prolactin. It's would not be a prolactin of 22, something kind of mildly elevated. Well, so when you're evaluating patients, they've come in to see you, and you're recommending a particular chemotherapeutic approach. And say, okay, well, how is this going to affect their fertility? So the types of the things that could happen for the chemotherapy, it could cause a zero sperm count or azoospermia. It could cause oligozoospermia or a low sperm count, or it could potentially affect just the quality of sperm and have some degree of functional infertility. For some of our cancer patients, this is going to cause an inability of patients to ejaculate. For spine or pelvic surgery, as I'll say in a case that's coming up, patients may have normal spermatogenesis, but they just can't get the sperm out, or could cause hypogonadism, which can impair spermatogenesis as well. So when you look at some of the agents that are generally considered lower risk, I'd put these on the lower risk. Many of these patients can have normal spermia after a period of time. I think the main point that's changed in my thinking, and when I speak to our oncology colleagues, is to say that there's no zero risk chemotherapy. And even though these are more favorable, there are lots of situations where it's problematic just to assume that things are going to be fine. Patients relapse, and then they need, within a couple of months, they need to have higher doses of chemotherapy. So just making the assumption that things are going to be fine because it's a low risk is risky to your patient's reproductive health. So err on the side of banking sperm whenever you can. It's often, as we talk about, there are barriers to getting that done, but err on the side of banking sperm when you can. I've been interested in targeted therapies for a while, and there's not nearly enough work that's done on the reproductive effect of targeted therapies, whether they're monoclonal antibody therapy and the slide I put up here is tyrosine kinase inhibitors. TKIs are thought to be pretty safe, and they may very well be pretty safe, but they have pretty interesting modes of action. Essentially, for a sperm to fertilize an egg, the sperm has to get into the woman's reproductive tract. It has to have membrane changes that allow that sperm to be more flexible and move. It also then has to bind to an egg and undergo the acrosome reaction. And these tyrosine kinase inhibitors can inhibit this process. It can also inhibit aspects of meiosis as well. So more work needs to be done. We found in vitro that it can have significant impacts. It's very difficult to study this from a clinical standpoint. It would be great to have phase 1 clinical trials incorporate reproductive impact going forward. So higher risk agents are these, and essentially looking at cisplatin, carboplatin, ABVD. These are higher risk, and you can see in the toxicity, the bullet points, that these can have pretty significant risks. These patients should bank sperm. And our highest risks are alkylating agents and induction chemotherapy for bone marrow stem cell transplants. Very high probability of sterility for these patients. From a radiation standpoint, the location, the dose is really impactful. Patients may have just temporary azoospermia if it's less than about 3 gray of exposure to the testis, but there's quite a bit of variability in that. It may only be 1 gray. So again, if patients are going to be exposed by either scatter or directly to the testis, you want to think about banking sperm. And azoospermia is pretty likely to be permanent as the dose goes up. From an endocrine standpoint, the testis can withstand more exposure. Generally, patients exposed to more than 30 gray are going to be hypogonadal. That would be far beyond the azoospermia threshold. So in terms of just looking a little bit about spermatogenesis and meiosis, I just want to spend the next couple of slides just giving you more information about that. When you look at a seminiferous tubule in detail, and when you stain for spermatogonia, these will be found along the inner surface of a seminiferous tubule. And the process of spermatogenesis is taking you from those stem cells all the way to sperm that you see in the ejaculate. From an anatomic standpoint, when urologists are operating on the scrotum, essentially we're making an incision through the skin, we're going through layers of muscle, and we're getting down to the testis. And when we get into the testis, depending on the surgery, we're opening up the outer layer of the testis and then diving into where the seminiferous tubules are found. The seminiferous tubules essentially drain into a structure called the Pedi-TeSE, and this is a collecting system portion of the testicle. And then from there's usually around a half a dozen of these straight ducts, and they're called ductuli efferentes. And so all of these are going into the head of the epididymis, or the caput, and then the corpus, or the body of the epididymis, and then the tail of the epididymis. And then from there into the vas deferens, and then out to the penis. So you'll see when we get to some of the experimental stuff, this Pedi-TeSE is an important area to know about. But the process of making sperm is happening on the inside of all of these tubules. And if we're getting in there and extracting seminiferous tubules, it's because we're trying to find sperm there. The process of spermatogenesis has a mitotic component, has a meiotic component, and then a cellular remodeling component called spermiogenesis. And so you essentially have stem cells that are dividing sporadically by mitosis, just generating more daughter cells, more copies of themselves. These are more quiescent, and they will not develop into sperm. This is your reservoir of cells that can eventually turn into sperm. From the differentiating type of stem cells, they're dropping into this pathway that I've put here on the right, and they're dividing at regular fixed intervals. And they're going through meiosis, and these do turn into sperm. And so if you look at these from a chromosomal content, as you're starting this process of meiosis, you're starting with a 2N type cell, chromosome from mom and dad, and you're eventually getting to a single N, which is 23 chromosomes. The last phase of spermatogenesis, you go from a round cell that has just N chromosomes, 23 total. And what happens during this process is you start getting rid of cytoplasm. DNA gets tightly wrapped around a protein core, and you get an elongating tail. And this is relevant for work, particularly that we saw in transgender patients. So again, mitosis, you get duplicative chromosomes. Meiosis, again, I'm not going through these details for this talk. Spermatogenesis involves both mitosis and meiosis, and reproductive hormones are essential for this to occur. And so this is really is critical from a transgender standpoint. So what could we do though for a patient who, like the one that we have here, where he has non-motile sperm? Well, we could do just a regular testicular sperm extraction, which means basically just make a small incision on the testis and extrude a little bit of the seminiferous tubules. But for a patient like this, I wouldn't recommend that to them. It might work, but the challenge is that sometimes the distribution of sperm production can be really varied. And there may be one small pocket within the testis that has sperm and others that don't. So for a patient like this, unless you just don't have access to a reproductive urologist who can do a micro-TeSE, I would do that. And so this is a procedure that for this patient where I knew he had sperm, I would line up the micro-TeSE with their IVF cycle. And so I would be looking to do the micro-TeSE either the day before his partner had her eggs retrieved or the day of her egg retrieval. I do this under local with sedation. Usually takes a couple of hours to do. The lab can take many, many hours to find sperm, even a really small number of sperm. The probability of success depends a lot on what they've been exposed to and whether you have any evidence that there's sperm there. So for this particular patient, odds are good you'd be able to find sperm. And this chart is from a study that essentially looked at the probability of retrieving sperm. The higher by testicular cancer, really just because the kind of chemotherapy that testicular cancer patients received, and lower where higher concentrations of alkylating agents are required. You can tell your patients, I mean, you find sperm, there's an excellent chance you're going to be able to use that to conceive. Well, what should our patient have done? Essentially, they should have banked sperm. And how do you counsel patients about what to use? So, and how to strategize about this. So usually the kind of back of the envelope information I'll give patients will be to say something like 50% of the sperm that you freeze will survive that freeze thaw, that ideally you'd have enough sperm to do intrauterine insemination, but you need to end up with at least 5 or 10 million sperm to get a chance at doing IUI. So you're looking at a starting number of at least, say, 10 million moving sperm. If you're doing in vitro fertilization, you need far fewer sperm, and there's, let's say, a 50% chance of pregnancy for every embryo transfer. So these are there are lots of things affect this, as our REI fellows and REIs know. But generally, if I saw a patient who had 100 million total motile count, I might do something like divide that into 4 aliquots. And so 25 million in each little plastic tube. And those would essentially be an IUI chance for each of those. And so we'd talk about, okay, what are your goals? How many kids do you want? And we talk about, well, maybe this 100 million would be fine with just one sample. Or maybe they want to really focus on IUI and I need to do this 2 or 3 times. What if they had 100,000? If they had 100,000 sperm, then I'd be thinking maybe also starting out with something like 4, but they're never going to get to the point where they need IUI. So I'd really be trying to strategize, how can I help them achieve their family goals that way? Well, why don't people bank? Sometimes believing that, well, I won't need it, perception that there's a small fertility threat. I have found, at least at UCSF, this is less of an issue. I don't think people really feel that way. It's more just the friction that it takes to get sperm banked that's, I think, keep people from doing it. It's either too time consuming. There are lots of other things going on. It can be very expensive. Doing it. Even at UCSF, where I really care about this, it's really complicated sometimes to get it done. So working at your home institution to try to make this as smooth a process as possible. Sometimes referring doctors just feeling like, well, you're not gonna need this. Or in the case of pediatric settings, that it remains experimental. But many people suffer significant regret if you don't go through the process of cryopreserving. Okay. So how about a different version of a testicular cancer patient? So this is a 35-year-old who had recurrence of testicular cancer. Patient had orchiectomy 4 years ago, received 20 grade of the retroperitoneum, developed a recurrence, and this patient underwent a retroperitoneal lymph node dissection 3 years ago. The couple had their first child 5 years ago before all this started, and they'd like to have another child. So what do we do? So when you look at these labs, how is this lab, or just consider in your mind how this pattern of labs is different from the first. So when we look at our FSH, our testosterone, both of these are normal. And so this is suggesting some amount of obstruction rather than a testicular impairment. The hormones are normal, so I'm not thinking this is a brain problem. Patient tries to produce a semen sample, but really is unable to produce a semen sample. So in this case, what you do is you look for evidence of retrograde ejaculation. So you'd order a semen analysis with a post-ejaculate urine analysis. So you collect a semen sample in one container, and then right after that, urinate into a second container, look for sperm. In this case, none to be found. So you think this is very likely a failure of emission of the sperm. It's just not getting from seminal vesicles out. So what is the composition of the ejaculate? So most of it comes from the seminal vesicle, a smaller fraction from the prostate and a smaller amount from the testicle. And this is why, for example, when we do vasectomies, that men rarely see any difference in the volume of their ejaculate. And if you see a patient who has no ejaculate or very low, most of the time I'm thinking there's some kind of a problem here at the ejaculatory duct level or the seminal vesicle level. So from a neurologic standpoint, and this is where it's relevant from our cancer patients, is that when you do a retroperitoneal lymph node dissection, essentially you're removing all the lymphatic tissue from the renal hilum all the way down to the bifurcation of the iliacs. And you're potentially impairing seminal emission or ejaculation, depending if you get too low, but you're not likely really affecting orgasm. Most patients will tell you that they have the sensation of orgasm, just lacking these other parts. Well, so how could we get sperm out for these patients? So in terms of our alphabet soup of acronyms for these patients, you could do a PESA, or a percutaneous epididymal sperm aspiration. You could do a TeSE, or sometimes pronounced a TeSE, but this is basically putting a needle into the testis. You could do a TeSE, a testicular sperm extraction, or you could do a microsurgical epididymal sperm aspiration. So essentially a needle into the epididymis, a needle into the testicle, or you could make a small incision and get testicular sperm out, or you could use a microscope and find tubules, find a little bit of fluid and get it out. There are pros and cons to doing this. It depends on the logistics that you have at logistical support you have at your institution. I found for us, the most straightforward way is to do a testicular sperm extraction, because I get a reliable amount of sperm to help REIs get 3 or 4 IVF cycles. Whereas with a TeSE, it's multiple needle passes to get often relatively small amounts of sperm. You need, for the PESA and the MESA, you need a microscope in the latter case, and a lab that can actually look at this fluid. And so not all urology setups are going to have andrology support. So it's just kind of figuring out logistically what works. You could also potentially do electroejaculation, that's where we apply electricity to the nerves of the prostate, the pelvic plexus. And this really works better for spinal cord injury patients. I mean, it's pretty tricky to do. You've got to do it in the operating room under general anesthetic. It's really painful. Otherwise, you have to do this repeatedly. And so it can be expensive, not covered by insurance very well. So it's pretty tricky. The benefit of it, though, is that you might end up getting, in this kind of a patient, you might end up getting many millions of sperm. And so they could do IUI rather than doing in vitro fertilization, or maybe one electroejaculation might lead to lots of IVF cycles. And so maybe they don't want an incision. You also need the equipment. Equipment can be expensive to get. So here's another variation of this. So a 45-year-old man presents to us, complaints of infertility for the last 5 years. He and his wife 10 years ago conceived without difficulty, had rectal cancer, had a low anterior resection at 40, and received FOLFOX. So he's basically cured at this point from his disease. He did not bank sperm. He has no antegrade ejaculation. He's not had any antegrade ejaculation since his surgery. So what can we do? Well, we get another semen analysis with this PEU, and again, no sperm. We see in this case, though, his FSH is very elevated. So here, I'm thinking this is a testicular impairment. And so what could we do for him? So in this case, I would do a micro-TeSE. We did find enough sperm for helping them conceive, but he then asks you about his ability to obtain erections. And so this will be a common question that will come up as part of the fertility evaluation. And so essentially it's the inability of a patient to achieve or maintain an erection. First-line therapies are generally medications, or if they're able to get an erection but lose it too quickly, to use penile rings. Second-line therapy would be vacuum erection devices, suppositories you can put into the urethra, or injections into the penis. And when all of these things fail, we'll put in a penile prosthesis. So shifting now to more of the cutting edge experimental work. This was a child who came into the emergency room with a brain tumor, and essentially had removal of the brain tumor, and he did well from that standpoint. His oncologist recommended that he get vincristine, methotrexate, etoposide, Cytoxan, and cisplatin. So a lot of big guns from a chemotherapy standpoint. I mean, the risk to this child of future subfertility or sterility pretty high. So plans, you have a week essentially to figure out what you're going to do. He's going to be getting a lumbar puncture in a central line. And so what can we tell them? We can tell them that the risks of chemotherapy are pretty high. And as you're evaluating these patients, the question will come up, well, could you get sperm? So for a 3-year-old, no, but the chance of getting sperm increases significantly as children get older. By the time children are 12, 13, 14 years old, the chance of actually being able to do a sperm retrieval and get sperm is pretty high. In fact, I had just this past week a 14-year-old transgender patient, and was about to start her hormone therapy, and she was about a Tanner stage 4, and we were able to. She was not comfortable producing a semen sample, and we were able to do a testicular, just a simple TeSE, and we're able to find lots of sperm for in vitro fertilization. They were super happy, but for a 3-year-old, not possible. We performed for this child an open testicular biopsy at the same time, and as there are other procedures. I guess some of these visits as the problem that they have. If the patients come over to you and you have a code, or your referring doctors say they're there for infertility, almost certainly they're going to be denied, but you're there to see them for complications, in this case of a brain tumor. So put in brain tumor, and that is usually covered. We'll usually code the surgery as testicular biopsy in the context of a brain tumor. Most of the time that's covered by insurance. As far as the banking of sperm goes, that's pretty variable, or banking of testicular tissue in this case. California nominally will cover this, but because this is an experimental approach, it may not be covered. So this is one of the costs the parents would have to know. They'd be freezing for many years potentially. So how can you potentially use this? Well, again, this testicular tissue is a pretty straightforward procedure. Kids heal up from this very well. I had been worried that children would have higher risks of infection or wound dehiscence, but I've not found that to be the case. We've probably done this about 40 times, and that we've had very few problems, little discomfort. From the ethical standpoint, it's specific to this age group. It's more about what happens in the event of a child's death. So for our adult patients, the adult would designate their spouse generally as the person who could decide what to do with the testicular tissue. But for these children, that should not be an option for them. And this came up really early on in our program, where we had a child who died, and mom came to me and said, okay, we've got this testicular tissue. What can we do with it? Well, what would that 3-year-old would have wanted, or that 5-year-old, or that 7-year-old, what would they have wanted and been in their best interests? So essentially, if a child is freezing testicular tissue, really only 2 options in the event of their death. They can use it for research, or they can discard that sample. You shouldn't offer that third possibility of parent being able to decide. Well, what do we do, or what are some of the most promising ways that we could potentially use that testicular tissue? So one way, and I'd say probably the most promising at this point for our cancer patients, is number one, is potentially taking this testicular tissue out, and one way or the other, getting it back to that patient after they go through chemotherapy. The idea of transplanting these cells back has been done for many years, since the mid-1990s in rats, of taking testicular tissue out, injecting it into the tubules of the epididymis, and seeing you could get resumption of spermatogenesis. And now this has happened in animals all the way up to monkeys, but never yet in humans. And this approach of taking this testicular tissue out, putting it back into the testicle, might allow natural conception and not have to do in vitro fertilization necessarily. Second possibility is to do in vitro maturation of these cells. You take the testicular tissue out, and ex vivo in a dish, you grow sperm, and this has some potential. I'd say though that again, you let the parents of these children know that using today's technology, even if we do nothing at all, there's still a chance that even if they were azoospermic, that we can use the technologies we have today. We do a micro-TeSE, we do in vitro fertilization, and there's significant chance of success. Well, how do you actually make this stuff happen? You should do testicular biopsies for these pre-pubertal kids under the protections of an IRB protocol. This is still experimental. Doing this at the last minute when kids are inpatient is not a good way. There's just so much logistics that has to happen. It's really is a multidisciplinary approach, usually with social work, hem-onc, urology. There's the cryopreservation process. For us, it's a referral through Epic or a direct email to me. My team, which includes a nurse practitioner, is reaching out to the families to do the consenting. I'm talking to the families about all of this stuff. I like telemedicine because I can show people slides, and they often have a lot going on, and I'll talk to them maybe while they're at their doctor's visit or while they're at home with their other kids. And so this has been pretty helpful for us. They need to get labs, 5 labs that they need to have to freeze their tissue, consent done, and then a lot of coordination between getting when they're going to get their port placed or their lumbar puncture done with the testicular biopsy. And so for us, we've built now a surgical team, the pediatric urologists, myself, the pediatric general surgeons, so that the logistics have become a lot simpler than when it was just me doing these biopsies. But again, refer people as quickly as you can, because it just takes a lot of time and effort to get it done. So Dr. Orwig and his postdoc at the time, Dr. Brian Herman, showed that you could do this in rhesus macaque. You could take this testicular tissue, you could inject it into the ready testis, and with many months of waiting, you could see resumption of spermatogenesis, even when you took prepubertal testicular tissue. So we started looking at this and published a paper just recently looking at human testis, and could you develop a model where you'd inject cells into the ready testis? And so this is from our paper, and essentially it is pretty straightforward for a urologist who's procedurally trained working on the testis to use ultrasound essentially to put a needle into the ready testis and then see retrograde flow of cells. We have not yet tried this in humans, though we're at the early stages of planning that out. Dr. Orwig continued his groundbreaking work, and this paper was published in Science, and showed that if you took this testicular tissue out, you transplanted under the skin of the monkey, either in the scrotum or underneath the back, that you actually got nodules of testicular tissue and or nodules of sperm-producing tissue. These monkeys had intact pituitaries. They were signaling to the testis to make sperm, but they were able to successfully find sperm in those nodules and do in vitro fertilization. There's a very cute little healthy baby monkey that lives up in Oregon, the primate center. Well, what about the in vitro maturation? So this process has been done really only in mice, and work done in Japan showed that it is possible to take newborn testicular tissue and lead to in vitro fertilization in healthy mouse pups. This hasn't been done much in other animal species. Well, I'm going to pause for just a sec. Wendy and Divya, do I have 5 minutes or 10 minutes?
Yeah, Leslie's with us. She's supposed to go on at 2, and you have a question in the chat that I didn't catch in time.
I'm sorry, Wendy, say that again.
We were going to have Leslie start at 2, and you have a question in the chat.
Okay.
Probably about 5 minutes.
Yeah.
Okay. So I think I'm going to just, not focus as much on the transgender stuff, other than say that it's not really it's not the same situation. The pre-pubertal testicular biopsies for transgender kids, I'm not in favor of doing biopsies for these kids. And I generally will wait until they're getting an orchiectomy before thinking to freeze it. We did that for this 16-year-old girl and got testicular tissue at the time of an orchiectomy, and we found these elongating spermatids. And so that they're even in Lupron, there's this potential for some degree of spermatogenesis. Perhaps these cells will be used full or could be matured in vitro. So I'm not going to focus on the transgender part. Just say you can find sperm in post-pubertal transgender patients, just at a lower level. So again, just some of the take-home points. Collaboration is really key. Refer early. Banking ahead of time is way better, and there are experimental options that are possible. And just discuss these options with families. So with that, I will stop and take any questions that people have in our last few minutes.
Yeah, thank you so much. There was a question about the third case. And maybe you could recall what the scenario was. Would you consider Clomid prior to micro-TeSE?
Often. So it really depends on whether the patient was hypogonadal. So if the patient had a testosterone less than 300 or so, then I would definitely be thinking about Clomid. If their estrogen was elevated, I'd be thinking about an anastrozole. Just recently, I was talking to Ranjith Ramasamy about how he manages. One of the challenges that you really want to get intratesticular testosterone levels up. And so you're using serum testosterone in this case as a marker for that. But Dr. Ramasamy from Miami has been using 17-hydroxyprogesterone as a marker for intratesticular testosterone. So I've just started exploring the potential for that, because perhaps my 300 serum level is not high enough, and I should be using Clomid more often than I have been.
Okay, another question from the chat. What is the concern for reseeding with testicular tissue banking, especially in hematologic malignancies?
So you're saying that somebody, for example, who had leukemia, and if we were to take a testicular biopsy in a leukemic patient, what would be the chance that we could take that testicular tissue, and if we transplant it back to that patient, what would be the chance of seeding? Well, it's a great question. I mean, it's something that I worry about for sure, and I probably wouldn't take that approach for a leukemic patient. At least in our early thinking about how we take the human step, that patient would not be a candidate for this autologous transplant. And I'd think more about that second approach, trying to grow sperm from their sperm stem cells, and that latter approach is how I would handle that, in the same way that I do that for a transgender patient. If I had testicular tissue, transplanting it back to a transgender patient who's taking Lupron, not likely to help them very much. And some of Kyle Orwig's work has shown that if you take a mouse and have even just 20 cells that are leukemic, and you transfer that back to that animal, they'll die. You'll get tumors that will kill the animal.
I just had a question. When you did the biopsy in the trans patient who had the orchiectomy, who was on Lupron, if I understood correctly, and there were secondary spermatocytes, is that haploid as secondary spermatocyte? Yeah,
so what happens in meiosis is that you have all of these round-shaped cells, these 2N-shaped cells that are on the inner surface of the seminiferous tubule. They're making their way through meiosis. They duplicate their DNA content and then eventually come down to just an N cell. So after 2 rounds of meiosis, you end up with a round cell that has just N chromosome. Okay. And then from there, from a round-shaped cell, you start kicking out the cytoplasm. You start tightly wrapping the DNA so that it's quiescent for sperm. It's wrapping it around protamine. Then you get a tail, a midpiece, and you end up with a sperm. So what I showed you was a secondary spermatocyte that is starting to go through spermiogenesis, that very last stage. And so once you're starting to see that tail, it's definitely an N chromosome content.
Thank you for that explanation. There's one more question in the chat, and then we'll take a quick break before Leslie starts at 1. So in patients who, due to logistics, are unable to bank sperm prior to chemo, do you counsel to wait the full 12 months after chemo before attempting to conceive? Do you ever coordinate banking in the first 2 weeks after initiating chemo? It's a great question.
Well, it really is a good question, and we've struggled with this. We don't really know. If I had a patient who they came a couple of weeks afterward, and we know, for example, they're going to be getting more chemotherapy, they would not be allowed to bank sperm at UCSF without a discussion with me. And essentially a really detailed risk-benefit discussion, me putting into their chart, they really were counseled about the potential risks. We don't really know what the risks are. There probably is some degree of DNA damage that's happened, elevated risk of mutations and birth defects, but we don't really know. Usually we'll say 3 months after completing chemotherapy, not necessarily 12 months. We'll kind of give a guideline as 12 months, but 3 months we would do it without much negotiating.
I have one patient whose husband banked within 2 weeks of starting chemo, and she subsequently had IVF miscarriages, but has gone on to have 3 children. But that was, maybe he wasn't counseled appropriately at the get-go. So we had to sort of, do the best we could with the situation we were at, but we were very nervous about the outcome.
One of the questions that comes up sort of in a similar vein is, well, what if we have enough sperm, we've banked sperm, but we have enough sperm to have sex? Should we use the bank sperm, or do we just use what is normally coming out? Generally, the data has shown that if you're able to conceive a pregnancy just with sex, you have enough sperm for that there's no higher rate of birth defects for those patients. So that's generally how we'll counsel people, that they don't necessarily have to use that frozen sperm.
Good to know. Well, lots of helpful basic science and clinical application of the knowledge. So thank you so much, Jim.